I'm Kader Torbator. I will be presenting an educational presentation on the uses of DMSA scintigraphy in renal functional assessment. Just a little bit about DMSA. Essentially, within medicine, it's the test of choice for pediatric cases of atypical and recurrent urinary tract infections. It helps us identify any loss of function secondary to scarring that occurs in individuals who go through a urinary tract infection. It is safe and simple. It has a high diagnostic sensitivity for the detection of renal cortical defects, and it is valuable test to use in addition to other diagnostic procedures, including an MRI or a CT scan, and can be used on its own in some cases. It is injected intravenously, and it's taken up by the brush borders of the proximal convoluted tubules of the renal cortex. And this is useful because the total renal uptake and the distribution of the tracer reflects the total renal function and the regional renal blood flow within the kidneys. And this will help us identify a loss of function because if the uptake is low, that would indicate a low renal function. Normally, a healthy kidney would have an uptake of about 40% of the pharmaceutical agent used in this imaging modality, which is dimer acid, at about 4 hours, whereas 70% at 24 hours. The administered agent, the volume of it and the mass of it is rather small compared to the contrast media used in MRI or a CT scan. So it makes it a pharmacologically safe agent to use, and it does not cause much of allergic or toxic effects, which is useful, especially in pediatric cases. And it helps with decision making, as identifying any loss of function would help us with surgical and medical management of children. So, as I mentioned, it is a test of choice for urinary tract infections globally. However, it has many other indications that clinicians may not quite be aware of, especially in secondary centers. And it helps, as I mentioned, with decision making. So it's quite a useful addition into investigations, along with more simple investigations such as an ultrasound scan or more advanced ones later on, such as MRI or a CT scan. So some of these indications are trauma, renal vascular hypertension, renal vein thrombosis. It can help us assess function in individuals who have hydronephrosis, complex renal calculi, individuals who've had a renal transplant, Wilms tumor, and certain congenital renal anomalies such as horseshoe kidney or cross-fused ectopia. I'll be given some cases of these different indications in the next few slides. The first being the common indication, which is urinary tract infections. Often we perform a DMSA scan 4 to 6 months after the initial infection to analyze for any loss of function secondary to scarring. And here I present to you a case of an 8-year-old child who had recurrent atypical urinary tract infections, and also actually had a stone within the kidney. The initial DMSA scan showed the left side had an uptake of 15%, whereas the right kidney had an uptake of 85%. And later on, this patient went on to have surgical intervention, left uretolithotomy, and 6 months down the line had a repeat scan, which I don't have the split function for, but comparatively, you could see the left kidney has much better uptake after the surgery. And then the next slide is a little bit about congenital renal anomalies. Again, we can use the DMSA scan to help us identify location and function of kidneys that are ectopic. This includes a horseshoe kidney or a cross-fused kidney, and it can again help us orientate ourselves and identify split function of different moieties. One limitation is that it does not give us drainage information and another investigation called MAG-free renogram could be used in those cases. So on the left lower corner, I present to a 9-year-old male with recurrent flank pain. And they initially had an ultrasound scan and then a DMSA scan, which showed that they had a single bulky right-sided renal unit with no functioning left kidney. And then later on, we performed a DMSA SPECT scan, which is a CT scan, which helped us identify again a right renal mass with a longitudinally cross-fused kidney. It is relatively well functioning, so they didn't have an operation after this. It was just that they were monitored with further investigations down the line. And then on the right side, a 5-year-old female who initially presented with urinary incontinence together with normal voiding pattern. And they had an ultrasound, a DMSA scan, which showed both of the kidneys were relatively well functioning. However, there was a photopenic wedge at the right upper pole, which I hope you could appreciate on the right side, which could have potentially indicated some scarring. But they went on to have further imaging, which was a T2 weighted MRI, which showed ectopic right duplex kidney with a small upper moiety shown by the blue arrow, which inserted ectopically into the vagina, leading to urinary incontinence. So this patient went on to have a right upper mole heminephrectomy. So only the area, the ectopic area that was non-functioning was removed instead of the whole kidney. And that resulted in complete resolution of the symptoms. With complex renal calculi, again, it's useful for us to identify any loss of function as a result of obstruction from the stones in the kidneys and secondary infection due to pooling of urine within the kidneys. And again, it can help us determine what is the best course of action in terms of surgical planning and treatment in these patients. So here I've got the scans of a 14-year-old female who had stones in the kidneys from the ultrasound scan, and the DMSA scan showed to us that both of the kidneys were actually equally well functioning. They went on to have a CT scan and DMSA SPECT scan with low dose DT, which again had a very good activity as shown in the images here. So this patient did not need any invasive procedures such as removal of the kidney, but instead had something called percutaneous nephrolithotomy, where the stone was removed percutaneously and then 6 weeks later had shockwave lithotripsy, which led to complete disintegration of the stone. Um, Here I present a case of a horseshoe kidney. The images are from an 11-year-old male who had stones within the kidneys together with recurrent urinary tract infections. And again, we performed a DMSA scan to identify any loss of function as a result of these conditions, and it actually showed patchy uptake with focal defects within the larger left moiety. They went on to have a CT scan, which showed that there was a non-obstructive calculi, which is the white bit you could see on the left side, with comparative thinning of the parenchyma of the kidney. And then the SPECT CT scan showed that there was actually some reduced activity in direct correspondence to the area of the renal parenchyma where the stone was. The useful aspect of a SPECT CT scan is that we can carry out 3D volumetric analysis, and here we can see that in the right lower image with the little pixels, 85 centimeters cubed of the right moiety tissue of the horseshoe kidney actually only contributed to about 13% of the total renal function, which is actually where the stone was. So this patient went on to have only a partial nephrectomy. The least functioning area was removed, which led to better functioning later on in the next follow-up images. And the last case I'll present today is hydronephrosis. This is essentially where there is fluid buildup within the kidney, so it is grossly dilated. and this again could potentially result in damage and loss of function of the kidney. Usually we perform an ultrasound scan in these patients, which will identify the grossly dilated and then a DMSA scan, which in this patient showed that there was only a small amount of reduction in the function of the right kidney with a 41% split function, which is a reasonable renal parenchymal function. So this patient actually went on to just have pyeloplasty instead of, again, removal of total kidney. And then in the next, on the right side again, we another case of hydronephrosis where the kidney is grossly dilated on ultrasound scan. They went on to have a DMSA scan, which, although it doesn't give, it was difficult to give a precise relative renal function, but the kidney that is grossly dilated is still functional. There is still good uptake. So this patient also had initial tube inserted and nephrostomy inserted to help remove fluid from this kidney, and then later on had pyeloplasty instead of removal of the whole kidney. Some of the limitations of the DMSA scan is that with movement, the quality of the images can be affected. And we cannot really perform the DMSA scan on the same day as other investigations, such as a MAG3, because the tracer from MAG3 would retain in the renal pelvis and could potentially alter the accuracy of our estimations from a DMSA scan. Infants less than 3 months have very immature kidneys, so they would have reduced uptake of the tracer, and so we won't again have very accurate measurements of renal function in infants. With recurrent urinary tract infections, patients may not actually fully recover from the infection within 4 to 6 months' time, and that could also affect our accurate measurements of renal function. So in conclusion, as I mentioned previously, DMSA scan is used globally for urinary tract infections, but it has many other indications. And there were a time a few years ago where the pharmaceutical agent wasn't very much available, and that might have negatively impacted clinicians from requesting this scan. However, it should get back into the swing of medicine. It should get back into the fold of imaging options because it helps early diagnosis and aids surgical and medical decision making. Thank you very much for listening. If you have any questions, please do let me know.